Good morning, Peter Goertz. I'm a psychiatrist. When patients lie to doctors, that's something I not infrequently experience. And this past 2 weeks, I saw two patients in emergency rooms, and one of them I was actually really tending to believe until I spoke with the family. So in ERs, I pretty much always try to get collateral information from the family or someone who knows the patient, because I've had to change my opinion many times after speaking with the patient. And my natural tendency is to believe patients until I know that what they're saying is not true, so to give them the benefit of the doubt. And one example of trusting patients is when I look back when I was a resident, when we were on call in the emergency room, psychiatric emergency room. It was a pretty big, just psychiatric emergency room in a city hospital. And sometimes at night it would be not too busy and we would get a chance to maybe lay down on a stretcher for about an hour or so. So we would be lying down on a stretcher in the room where we would evaluate the patients, and right outside our room in the corridor would be patients lying on stretchers. So it was kind of like a community, not safe necessarily, of course. There was, of course, that downside, but it also, on the other hand, created somewhat of a feeling of a community, that we shared space with each other and respected each other. And to my knowledge, nothing bad happened to any resident, at least while I was working there on call during those nights when there were patients sleeping in the hallway right outside the office where the doctors could sleep sometimes. So how do we feel as doctors when we notice that we cannot trust the patient, that a patient lied to us? For me, that's been difficult over the years. I don't like that feeling. On the other hand, we want to remind ourselves, generally, patients are not being malicious by lying. They're human, they're fallible, just like us. And it's somewhat similar, the doctor-patient relationship is somewhat similar to a marriage in certain respects. We both have responsibilities, so we're entering into a relationship where we're, as doctors, responsible for giving the patients good care, medically, psychiatrically, and the patients are responsible for telling us what's going on and being truthful. But of course, that doesn't always happen. And an aspect that's worth looking at is if our relationships with our patients are not enjoyable, our work satisfaction is going to be poor. So we want to, as much as possible, have enjoyable relationships, trusting relationships with our patients. Again, not always truthful. Now, of course, that also brings up the issue that we ourselves, as doctors, want to be truthful. And that can be tricky sometimes. So if we've made a mistake and the patients ask us about that, we want to be truthful, in my opinion, and admit that we did something that was a mistake. And that's happened to me many times. And even in extreme cases, this wasn't directly my mistake, but even in an extreme case where patients were being, by mistake, many years ago, being given on a psychiatric ward, because of a mix-up, they were being given each other's medications, which is really bad. And a patient noticed that, and I admitted it to the patient, and that, I guess, was disarming because he accepted that and just let it go. Before that, he was quite upset and generally had been quite a caustic, irritable patient. So being truthful on our part also, I think, is very important. Now, do we want to be policemen? In general, I think doctors don't want to be policemen with regard to their patients, but different doctors have different styles. Some doctors want to check more, some doctors want to check less. And when I say checking, that could be lab work, getting history from someone else, from a wife, let's say. And as far as, for instance, another example of trust, would a wife want to always have her husband checked to make sure he wasn't with another woman every time he gets home. Some wives maybe, but that would tell us something about the relationship also. So we want to ask ourselves, what relationship do we want, and do our best to make it as trusting as possible, in my opinion. Now, we also want to be realistic and look at what looks like is in front of us, what the situation is. So we want to not hesitate necessarily to get a urine toxicology screen. If someone's on a stimulant like Ritalin or Adderall, we want to get a urine tox, potentially at least, and see if they're using other drugs like cocaine. So that could really be a problem if someone is on Adderall and additionally using cocaine. That could be a cardiac issue that could put them in cardiac arrest potentially. And on the other hand, if a patient on Adderall has a negative urine tox, so the Adderall, the amphetamine doesn't even show up, that may be telling us potentially that they're selling the Adderall. So there are different aspects. I mean, potentially, of course, they could be using the Adderall only twice a week or something like that, and the urine tox is negative. But we want to look at these things and be careful. And for alcohol, we could get a PEth test. If we're suspecting a patient is lying to us about alcohol use, the PEth test would tell us in the long term whether the patient has been drinking significant amounts of alcohol or not. Now, patients can also lie to us about taking medicine. They may say, I take it every day. And then we think, oh, they're still depressed. It's not working. Let me increase the dose. Let me prescribe a higher dose of the antidepressant. Now, potentially, if the patient then starts taking it at a higher dose, that could be dangerous because they hadn't been taking it at all or very little, not as prescribed previously. So that's another pitfall. And potentially, at least in some patients, the more suspicious we are, the less trustworthy the patient is going to become. So it could be the patient may pick up on us feeling suspicious about the patient and maybe even unconsciously or subconsciously then become less trustworthy because they feel we don't trust them anyway. So there are various aspects, and it seems wise to me to be as trusting as possible with patients, but as suspicious as necessary, and that's always a judgment call. Sometimes things are obvious, telling us, oh, we need to really be careful with this patient. Let's say if they seem obviously intoxicated during an outpatient visit in a clinic. In emergency rooms, like I mentioned, I pretty much always want to try and get collateral information because part of what we're deciding in an emergency room in general is, does the patient need to be hospitalized psychiatrically or not? Are they safe? Generally, with outpatients in my clinic, even during the initial visit, I don't get collateral information, which may at least sometimes be a good idea if it's okay with the patient. You want to get the patient's consent. Whether they're in the ER or in the clinic, you want to get the patient's consent. And lab work can be helpful, routine lab work even. Let's say a patient in an emergency room totally denies using alcohol in the last few months, but the MCV, so the size of the red blood cells is high, the platelets are low, the AST is high. Those would all be signs consistent with alcohol use, so that could give us some idea of what's going on, even when the patient is saying they are not using alcohol. Thank you.